Okay, I'll go ahead and get started, and then my fingers are crossed that my dog stays occupied. I gave him a bone, so hopefully he'll let me speak in peace. Like I said, my presentation is going to be about the Iowa Newborn Screening Program, and we're going to take a little look at what we've done to address some changes that need to be made regarding the pandemic. And then also, we were lucky enough to experience a natural disaster, a derecho, in August. So I will talk about some of the kinks that threw into our program too. Next slide, please. And I'm going to go quick, so fasten your seatbelts here. I'm going to go through kind of quickly so that we have some time for discussion later. So the COVID-19 impact to our program really hasn't been any different than other state newborn screening programs. We're all in the same boat together. And newborn screening is a system of care. So what affects one component of the system affects all the system, the whole system. With newborn screening programs, the effect that the pandemic has had is that we really don't have any backup. In the past, we've been able to rely on other states, our partners in other states, even our partners in other programs or other countries. But of course, now that's not been an option. We're all in the same boat and dealing with the same challenges that the pandemic presents. The best made continuity of operation plan were not really built or didn't address worldwide disasters such as a pandemic. They were generally more local or at least nationwide, but definitely not worldwide disasters. And most of the newborn screening continuity of operation plans are lab or testing focused, and they haven't included follow-up and referral parts of the newborn screening program. And I would argue that those are the most COVID-19 impacted components of the newborn screening program in Iowa. And then we did learn a lesson from the flooding of the Missouri River a few years ago that affected the west coast of the state and our neighboring states there. And many families were displaced then. And the lesson that we learned is we started asking for their cell phone number or an alternate number on our blood spot collection form. So that's something that we've kind of have learned in the past for that. Next slide, please. I'm going to talk kind of component by component of the newborn screening system and what has happened there. Hospitals, as we all know, are short-staffed. Many staff have COVID. There are illnesses that are going through the staffing. There are nationwide shortages of nursing and medical staff, and then we have burnout. Staffing gets assigned to other units. There's much extra work involved on a day-to-day task, such as testing employees, isolating employees, gowning and gloving for PPE. The parent support that's needed and reporting requirements for what's going on within the hospital. Primary care providers are also short-staffed and increasingly busy, especially the pediatric providers. We're seeing delays in reviewing or missing, or that they're missing abnormal results and our requests for confirmatory testing. And then when our short-term follow-up program contact the primary care providers' offices, they're on hold between 20 and 40 minutes before they can talk to someone in the primary care provider's office. So they are definitely having to wait a long time in order to communicate or have some conversation about abnormal newborn screening results for the primary care provider's patients. Some clinics closed or have limited hours, especially those that are hospital-based. Like our cystic fibrosis clinics, they closed initially. Now they're seeing patients in limited hours for sweat testing only. The newborn screening program had to change our CF protocols in order to effect treatment while waiting for confirmatory results. So before, we used to work with our CF centers to coordinate the care and confirmatory testing along with next steps and addressing those abnormal initial newborn screening results. But now we're just going straight on to sweat testing, or we're moving directly to the second tier testing if there is a presumptive positive newborn screen. Families are resistant to visit the clinics and healthcare facilities. For example, we're seeing a decrease in hemoglobinopathy appointments, and we're seeing more and more no-shows for those appointments. Next slide, please. So in Iowa, we use a courier service. We have a state-based courier service that picks up all the newborn screening specimens from the hospitals or the birth care providers and delivers them to the state hygienic lab every day. The impact of the couriers were that we had to do some rerouting and reschedule pickup times due to the derecho damaged areas. There were debris on the roadway, et cetera, like that. And since hospitals were locked down, they were unable to get to the usual specimen pickup location in the hospital labs. So we had to work individually with each hospital lab to make other arrangements so that the courier could get to the specimens for pickup. The courier became bombarded with COVID pickups. The same public health lab does the COVID testing, as does the newborn screening testing. And while the newborn screening remains a priority, it definitely did impact the ability to make the routes work, the courier routes work. The courier director had difficulties getting new drivers hired because once they heard about COVID, that they were going to be collecting COVID specimens, they weren't really comfortable with it. The lab had regular meetings and sharing with the courier director what the real risks were and how to properly handle and store the COVID specimens. And this went a long way, as well as making sure to include him as a partner and seeing what resources were needed to continue the operations that are so very important. And then additionally, the State Hygienic Lab received samples from Alaska and was previously getting those by commercial flights. And while those flights definitely were impacted, the coordinator in Alaska had to look at a backup plan and make arrangements with FedEx to send samples. And fortunately, the timeliness goals were not compromised significantly with that, which is amazing when you consider that Alaska is flying specimens to Iowa on the same day. For testing. So they were able to, with all the flights that were canceled, commercial flights that were canceled coming out of Alaska, they were able to ramp up pretty quickly with FedEx to get those specimens flown into Iowa. Next slide, please. Another component and a big one is our State Hygienic Laboratory. That is our centralized testing laboratory for the Department of Public Health. As with other programs, we have staff working from home. We have staggered their work schedules. We already have 2 shifts. We have a day shift and a night shift in the lab, and staff were able to kind of flex their hours for either the day shift or the night shift or even overlapping shifts so that we didn't have as many people working in the same physical area at one time. We reconfigured the work areas to provide for some distancing. Of course, there's no extra visitors to the State Hygienic Laboratory. We work closely with the courier to obtain those specimens from the hospitals, as I had mentioned before. And the infrastructure that has been impacted mainly is our information technology services. We were in the process of developing a new laboratory information management system for newborn screening, but that has been put on hold because the IT resources have been redirected toward the COVID response. Next slide, please. The follow-up component of the newborn screening program, we've been unable to fill vacant non-essential positions due to the financial situation at the University of Iowa hospitals and clinics, which is where our short-term follow-up staff's housed. And that's due to limited or restricted services such as services. So hospitals and clinics' financial situations gotten a little more tight that way. This also required short-term follow-up staff to take mandatory unpaid leave or use vacation time, at least 1 week of that. And then physicians had to take a 5% pay cut. All short-term follow-up staff are contributing to some kind of COVID-19 response at the UIHC. They're monitoring entrances, doing temps and assessments of anybody coming in and out of the hospital. They're taking temperatures, providing patient transport, and the newborn screening medical director is staffing the COVID-19 triage telehealth part-time. We have been unable to have newborn screening program staff or non-UIHC staff come to UIHC for meetings. So I am physically located in Des Moines, which is about an hour and a half away from the University of Iowa hospitals and clinics. And we would travel back and forth for meetings all the time. So that's just kind of been something different that we're not alone. Everybody's had to deal with that kind of stuff. But that's been something that we've had to reconfigure, if you will. Staff is working from home, but unfortunately they weren't able to get VPN access. So they're working on a less than ideal remote platform right now, and they've had difficulty getting needed hardware in a timely manner, as including extra monitors, more than one monitor or their laptop monitor and stuff like that. As I mentioned before, contacting the primary care provider, our follow-up staff has been on hold between 10 to 40 minutes before they can talk to someone in the primary care provider's office. And then they're having to make very client-specific arrangements for repeat and confirmatory testing rather than relying on the primary care provider to get it scheduled or to collect the specimens themselves, just because of the volume and the circumstances that the PCPs find themselves in right now. Next slide, please. And then adding insult to injury, we had a derecho on the 10th. It was over a 770-mile long track over 14 hours time. It lasted for 14 hours, and that went from Nebraska through Indiana. We had 60 to 120 plus mile per hour winds in Iowa, and we had hundreds of thousands without power, some for over a week. And of course, internet and some communication capabilities took a lot longer online than the power did. The power had to happen first before the internet service and other communication service providers could get there and get that hooked up again. We also competed with Hurricane Laura in Louisiana for resources. So our electrical and cleanup crews, insurance appraisers, contractors, all of those types of agencies were already down in Louisiana in anticipation of the hurricane. This derecho wasn't something that we could have predicted. So this surprised everybody. These are just some pictures of some of the damage that happened with the derecho in Iowa. Next slide, please. Some of the complications that came from that, again, as I had mentioned, there was no power, no internet or phone service. Clinics had to close because they just didn't have any way to operate, of course. There were many families displaced due to power outages or damaged homes. The roads were impassable in some areas. The newborn screening staff had the same issues as everybody else. So, you know, we're just like everybody else. So both in Des Moines area and in the Iowa City area. So our homes were without power. We didn't have internet. We didn't have the communication capacity that we used to have had. And then some staff had to go into the office to work because they didn't have any power at home or any internet at home. So that was the only way that they could actually work, was getting into their health system or their offices to do their work. Trees and other structures needed cleaned up before the power could be restored. So if trees were on power lines, we needed to get that cleaned up before the power companies could come and restore the power. That needed to happen before the internet communications could be restored. So this was a definitely weeks-long process. And I traveled across the state a couple of weeks ago, and I noticed there was still a lot of damage out there. And you can see the new roofs on homes and out structures. Some roofs still had tarps over them because they just weren't able to get them fixed yet. Next slide, please. So one thing that we need to be sure that we're recognizing is the toll on everyone's mental health and morale that both the pandemic and the derecho have had on everybody. So people are not getting breaks. It's difficult to schedule any time off because we are short-handed, and because things need to be basically changed on the fly, if you will. Morale definitely was impacted by the forced or unpaid leave or vacation use time at the University of Iowa hospitals and clinics. And since staff were forced to take time off, then we also had that caused short staffing as well. Everybody's missing their coworkers and the social interaction that you would have your coworkers. There's some burnout. It's hard to see the light at the end of the tunnel. Now that there's a vaccine happening, yay, maybe there's a light there. And then in addition, all of the personal and home life stress that come along with that. Next slide, please. Some of the policy impact that we experience here, or that we had conversations about, was we requested a statement from the director of the Department of Public Health and the governor's office that newborn screening is considered an essential service even during this pandemic. And although the Iowa Department of Public Health and State Hygienic Laboratory were untouched as far as reallocation of staff and resources from newborn screening to the COVID-19 response, despite an understanding by the Department of Pediatrics Administration, the short-term follow-up program at the UIHC is at the service of the hospital CEO and was impacted, but not to where any of the short-term follow-up services were compromised. And we had many general discussions with our State Attorney General's office about exceptions to policies and waivers to our laws and our administrative rules. Next slide, please. We do have 2 grant-funded projects that we're working on, ancillary to our regular newborn screening program activities. We are in the middle of conducting a spinal muscular atrophy newborn screening implementation pilot. So we are screening all newborns in the state for SMA right now. We are not reporting out normal results. We will report out abnormal results, but we do have a grant for that, and a CDC grant for that. And that has managed to go along pretty smoothly. It hasn't been impacted by the pandemic. Another project that we have is an APHL quality improvement project, where we are looking to introduce newborn screening education in the prenatal period in OB offices. So maternity care providers, prenatal care providers. And what has happened there is that we were unable to get to the prenatal care providers early on in the project because they were closed. They closed a couple of clinics with the pandemic. And of course, they weren't able to allow anyone extra to be in the clinic. So we weren't able to get there and have conversations with them about what type of education we wanted them to present to their clients, and how that whole process was going to work. So we had to, about 3 months later, we're finally now getting back to those offices and clinics in order to provide that newborn screening education in the prenatal care period. And that was my last slide, but a couple of things I want to make sure that I address is that there were some questions that we've been provided that they wanted us to talk about. And most of them that I want to mention is, what can the rare disease community do to help out newborn screening programs during the pandemic, or what should they be aware of? One of the main things that I mentioned early on was the fact that there should be a policy in place that newborn screening is seen as an essential service, and it should not take second place, if you will, to pandemics or epidemics or anything of that nature. So we've ended up having to compete for resources, and especially with the lab, and that shouldn't be the case. So there needs to be some kind of, if not a statewide policy, then at least a national policy that newborn screening is an essential service and should be able to have the same resources that they need to continue their operations. There should be some kind of standardized test prioritization. So what we've had to do at the lab is there's been a shortage of some of the consumables or the supplies that they use for testing. And since they can't get as many supplies as they need, we're looking at prioritizing, okay, these are the tests that we need to make sure that we get done every day. So those are the time critical disease conditions. And then what conditions can kind of wait because we don't have those. So what can we do every other day or once a week? Are there conditions that we can space out instead of doing every day like we would normally do? So it would be helpful if there was some kind of standardization around that process. And then every state is updating their continuity of operation or their emergency management plans right now for newborn screening. And I would encourage individuals or families or the rare disease community to get involved in their state's planning and updates of their operation plans. We would like to have individuals involved in helping us do that. There's no way that we can know everything that we need to consider when we are updating these plans as far as what the potential impact to families would be during a disaster.